Welcome to a GSA Policy Profile, the GSA On Aging podcast series. GSA Policy Profiles provide insight into current aging-related policy issues from those at the forefront working to develop evidence-based policy.
Thank you for joining this Policy Profiles podcast installment, which will explore the latest research and federal policies around social isolation and loneliness. I am Apoorva Rangan, an intern here with the Policy and Professional Affairs team at the Gerontological Society of America. And joining us for our discussion today is Morgan Bailie, the Policy Director of the Foundation for Social Connection Action Network, which GSA is a founding member of. Morgan Bailie brings nearly a decade of experience in mental health and substance use prevention and treatment to her role as the Policy Director for the Action Network. Her experience in behavioral health includes payment and delivery transformation, integrated care, and workforce development. She also has a broader background supporting patient primacy, non-discrimination, and community-based care. Her work is driven by a passion for improving the healthcare system and ensuring access to care for all communities, including addressing the growing epidemic of social isolation and loneliness. Morgan has a deep set of experiences in the Substance Use and Mental Health Services Administration, or SAMHSA, and previously served in legislative and regulatory capacities for the American Academy of Family Physicians. Morgan, we are so pleased to have you here as a friend and close colleague of GSA to discuss a topic that structures so many of our lives and communities.
Thank you so much for having me. I'm excited to be here.
Amazing. So let's get started. In recent years, we saw growing federal recognition of social isolation as a public health priority. For example, the former U.S. Surgeon General issued an advisory titled Our Epidemic of Loneliness and Isolation. First, could you help us understand the distinction between those terms, loneliness and isolation? And could you walk us through the significance of these developments and what they have meant for federal funding, research, and service delivery?
Yeah, I think that's a really wonderful place to start. So we often refer to social isolation and loneliness together, but they are two distinct things. So social isolation refers to having objectively few social relationships, social roles, group memberships, or infrequent social interaction. So you can think of homebound older adults or disabled individuals, maybe rural Americans without broadband access, someone living in a historically disinvested neighborhood without community spaces or social clubs. They might have very few social interactions on a daily basis. So that's social isolation. Loneliness is a subjective, unpleasant, or distressing feeling of a lack of connection to other people, along with a desire for more or more satisfying social relationships. The discrepancy really of how connected you feel versus how connected you want to be. And I think that's an important distinction because someone like myself, who's a little more introverted, I don't mind not connecting with people on a daily basis, but others might want deeper social connection. So you can think of an LGBTQ person surrounded by people, but unable to or afraid of expressing themselves authentically, or maybe a new parent with friends who don't have kids, or vice versa, someone who doesn't have kids and all of their friends do. So lacking that authentic social connection that they desire. So that's the distinction between social isolation and loneliness. And we know that both of those things are associated with increased risk for heart disease, stroke, Alzheimer's and dementia, diabetes, depression, suicidality, elder abuse, hospital readmission, and premature death. So it's a pretty long list. And in 2023, 1 in 3 adults age 50 to 80 reported feeling isolated from others. So 1 in 3 adults, that's a lot, but it is a positive shift away from some of the COVID era statistics where 56% of adults in that age range felt isolated. So we have a long way to go, but we're making some progress here following our COVID era. And then we've known about the association between health and well-being and social connectedness for some time. So a study from 2010 showed people with stronger social relationships had a 50% increased likelihood of survival across all mortality types, meaning heart disease, cancer, renal disease, neurological disease, more and more. And so just to say that again, a 50% increased likelihood of survival, that's a pretty huge statistic. And so we've known about this this relationship between health and social connection for some time now, even before that 2010 study. So really getting to the heart of your question here, the federal recognition of this health epidemic really speaks to a core thesis. Isolation is not a personal problem, but one rooted in community design and systemic barriers. And so to me, really that means we need to move beyond individual level solutions to a culture of connection and changing our policies, our system, our environment, and that involves stakeholders from all sectors of society, including federal and state partners. So really when we get to the level of federal recognition, it's really a recognition that many stakeholders need to come together to address this.
That is a super clarifying response. I am struck by how connection, whether it's measured through this objective measurement of, for example, the number and type of social roles that you participate in, or whether it's measured through that internal sense of authentic connection, that kind of both of those have the effects on individual health and well-being. I am an aspiring physician. I'm hoping to work extensively with older adults, and I am struck by how isolation is this problem and this issue that we're developing awareness of with real health effects that is structured by the community. So really eager to hear more about this kind of multi-stakeholder effort to address this growing issue. I wanted to ask you, and drawing from your experiences working to build these coalitions for social connection, I'm curious how the recent passage of H.R. 1, better known as the Big Beautiful Bill, affects your work to promote community building and social isolation and loneliness.
Yeah, absolutely. And I want to take a second and just applaud your career trajectory. That's incredible that you plan to go into medical school or maybe are in medical school already and working with older adults. So that's fantastic to hear. But back to your question on HR 1, unfortunately, it is already having a chilling effect on some of the conversations that we're having with states, and most of the healthcare provisions haven't even gone into effect yet. So most of us have heard the numbers so far. HR 1 cuts over $1 trillion in federal healthcare spending, primarily from Medicaid and the expansion population. We know that states are under pressure to address Medicaid budget impacts. We also know that when states face difficult budget cuts like the changes in Medicaid financing, it won't be just the Medicaid population that's impacted. Medicare beneficiaries are likely to see changes as well. So also of concern, of course, is the ACA expansion population, so those covered by Medicaid under the ACA expansion. So that includes many older adults and disabled individuals. So while these folks may not be immediately unenrolled from their coverage, many may face soaring premiums that are unaffordable or face significant administrative requirements to submit documentations to meet work requirements. We've already seen that these work requirements in certain states led to unenrollment, not because people aren't meeting the requirements, not because they're not working or not exempt, but just simply because the documentation is confusing or unclear, or no one reached out and told them that was changing. They didn't have a correct address on file and it hadn't been updated in a while, so they never knew about the change. And then they lose their healthcare coverage, and many of them will find out when they go to fill that prescription or get a bill in the mail after seeing a doctor that they thought was covered. So while HR 1 may not have specific Medicare provisions affecting older adults, we're already seeing a sort of scramble to address care for all populations, which I believe will also mean less focus on innovating and improving social connection initiatives. And really, that is just some of the health-related provisions. There's also provisions around SNAP and nutrition programs and more that will have an impact on older adults. I feel like we could talk for a full hour and a half around HR 1 and all of the impacts that will have. But I think a lot remains to be seen on how this happens on a state-by-state basis. But I do also want to take a little bit of time to address a more promising bright spot. So the Medicare physician fee schedule, which as an aspiring physician, I'm sure you'll come to know very well if you don't already. But in particular, this year, the fee schedule, which was just released a few weeks ago, there's an RFI on chronic care services, and it highlights social isolation and annual wellness visits and the area agencies on aging, or AAAs. So specifically, this RFI asks about the evaluation of services being performed to address social isolation and loneliness and the impact of these services. Another question in the RFI acknowledges the over 600 AAAs and that unmet need exceeds current funding levels. So really great to see that acknowledged in a CMS publication. It also goes on to ask how the fee schedule or the Innovation Center, also known as CMMI, could better support partnerships between clinicians, AAAs, community hubs, and the broader aging network. So while this is really just a request for information, it speaks to broader thinking in the administration, or at least in CMS, of how seniors can be better served in a more innovative way and how those services can be sustainably funded through Medicare, which is a pretty important piece to ensuring continuity of these services. So we're in a mixed sort of bag here where we're seeing a lot of sort of crisis on what's happening in Congress, but I'm also seeing some bright spots coming out of CMS.
When I hear you talk about the effects of HR1, especially disruptions perhaps to services, I think of a dual eligible individual who I worked with when I was in college. He's still extremely dear to me, and I am in touch with him pretty frequently. He's 60 and lives in Boston with cerebral palsy, and his PCA, Christine, was actually a major source of social support, not just that caregiving support, but also friendship and connection. She knew and celebrated his birthdays and provided him with his favorite meals that she made herself on her own time. And I am just feeling both a little bit apprehensive for the ways in which relationships of care and companionship like that, which my friend has experienced and is part of his life, might be interrupted, but also feeling some optimism that a federal regulatory body like CMS is focusing on connection and social isolation in their requests for information. That seems really promising, just to even get a better sense of what the research says about the health impacts of these issues and communicate that to CMS. So that's really great to hear.
Absolutely. And it's important to remember HR1. We still have about 2 years until many of the provisions go into effect, but states are scrambling a little bit to figure out what that means for them. But we do still have some time before that impact is trickling down to people like your friend that you mentioned. And hopefully we have time to respond to this RFI and share all of the important ways that work from the healthcare community on social isolation and loneliness can help improve outcomes, because really that aligns with what this administration is looking to do with chronic disease and ensuring a healthy America. And any way that we can get that across the finish line, I think will be a huge win for our community.
Amazing. So we are celebrating the 60th anniversary of the Older Americans Act this month. Could you highlight some key provisions of the Act for promoting community building? I know you had mentioned the area agencies on aging, and discuss the Foundation for Social Connection Action Network's advocacy asks for its upcoming reauthorization, especially given HR1 and some of the changes that we had mentioned.
Yeah, absolutely. So the OAA dates back to 1965, and it includes several provisions that emphasize social connection, community engagement, and reducing social isolation among older adults. So just a few that come to mind for me: Title 3B, which specifically funds, it's the supportive services and senior centers provision, and it funds the services that help older adults remain independent and connected. So that includes transportation, senior centers, legal assistance, and much more under that provision. And then also Title 3D, the disease prevention and health promotion services. It includes evidence-based programming like group exercise or fall prevention classes. So it's not only encouraging physical activity and healthy living, but also including that connection piece of coming together for a shared class, a shared experience. We're also seeing work done through the Administration on Aging, which is established in Title II of the OAA to focus on promoting community-based systems of care and collaboration with local agencies to prevent isolation. The same is true for the titles authorizing research and demonstration projects and services for Native American elders. The 2020 amendment to the OAA also explicitly recognized social isolation as a serious health issue, encourages social engagement programming, and newly supports technology initiatives to help older adults connect with friends and family, as well as services digitally. So we're seeing some progress on the technology front as well, which is great. But as you might know, or your listeners might know, formal authorization for the OAA expired in 2024. The Senate did unanimously pass legislation to reauthorize the OAA, which was huge, but unfortunately, it didn't make it through the House. It didn't make it through end-of-year funding packages. So we're hoping to see that authorized and appropriated this year. And it may seem like wordsmithing to some, but as we talked about at the top of the call, we want to be sure that the OAA encompasses both social isolation and loneliness. And to me, that dovetails nicely with another priority of the Action Network outside of the OAA specifically. So we've endorsed the Improving Measurements for Loneliness and Isolation Act. It's HR 1305. And it's a bipartisan bill that would help standardize the measurements of loneliness and isolation. As I cited a few at the beginning, we have plenty of studies on social isolation and loneliness, but we don't really have a common definition across federal or even state agencies. So it's hard to provide a comprehensive look at this federal data. So this bill would ensure all federal agencies have input into these standardized definitions and that they're all speaking the same language when analyzing data or funding critical interventions. And then we're also hopeful we'll see more legislation on intergenerational social connectedness. As we all know, older adults don't live in a vacuum, and providing more third spaces and intergenerational engagement will not only improve connectedness among older adults, but also among young people, parents who may feel isolated, and really people of all ages looking to build community. So I really appreciate our conversation today. And for those folks who are looking to get more involved, the Action Network is always here. We can include some resources in the show notes. And we're continuing to advocate for the Older Americans Act and other legislation to promote social connection. And it's been a great joy of mine to help engage in this effort.
Thank you, Morgan, for helping us navigate the evolving federal landscape and its implications for social isolation and loneliness. And thank you to our listeners for joining us today. We'll include all the resources we discussed during the podcast in the show notes, and you can listen to more policy profile podcasts on GSA Enrich.
Gerontological Society of America was founded in 1945 to promote the scientific study of aging, to cultivate excellence in interdisciplinary aging research and education, to advance innovations in practice and policy. For more information about GSA, visit geron.org or geron.org.